Welcome everyone to a Thursday night, 8 o'clock, the new way of doing things on Zoom. Much appreciated that everybody's joining us tonight. My name is Chris Peebles. I am the clinical account manager with Nodal Vision in the Mid-Atlantic region, and we are super excited to present with Dr. Garfinkel tonight. Just a little bit before I get him going about Dr. Garfinkel and a couple of housekeeping items. As we get going, if you have questions, they will be answered at the end of the presentation. If you're not familiar with Zoom, you can just scroll your mouse over the presentation and a Q&A box will come up and you'll be able to type in your questions and we'll pick those out at the end and let him answer those questions for you. Everyone is muted, so you should be fine as far as any background noise, but if not, please let us know. Dr. Garfinkel has been a friend of ours for a long time. He's just on a personal note, a super guy that's been very friendly to me as I got started with Nodal Vision a few years ago and has really helped me, mentored me in the area. He's with Retina Group of Washington and has hospital appointments at Washington Hospital, Fair Oaks Hospital, and Friendship Surgery Center. He's a clinical assistant professor at Georgetown University and has a courtesy appointment at the Inova Fairfax Hospital. He's published articles and numerous publications and more than 40 abstracts and presentations in his career. He's active in clinical research and found out today he's actually an avid runner. So he ran a little bit today to get us going get all jacked up for tonight. So I'm going to turn it over to Dr. Garfinkel. Rich, it's all yours.
Thanks, Chris. I want to welcome everybody to the presentation. I hope it's an educational night for everybody. I'm Rich Garfinkel from the Retina Group of Washington, and I just want to point out that I don't have any relevant financial disclosure for this presentation. Now, the current COVID crisis has had an impact on all of us, both short-term and long-term, and there are a lot of questions that remain both for us and for our patients. We're going to get into a lot of this. We've got to decide if this is the new normal and if this is the way we're going to continue to practice, and it's probably not. We're probably going to make changes over the course of the coming months that are going to stick with us, and hopefully most of those changes will be positive. We need to figure out how we're going to stay connected with our patients throughout this time because a lot of them are afraid to come in, and we've got to keep them protected during this crisis time. So we're going to talk about a number of those things, and then I'm going to review with you my experience with the 4C Home, really the true first telemonitoring in ophthalmology. And then we're going to talk about telehealth as it is today and how I think and how I've been using it in our practice to help me get to know my patients better and to help them better. So we're going to go over those things in that order. You know, our patients, these seniors who have dry age-related macular degeneration are really in two high-risk groups. They're at high risk for COVID virus infection and for having difficulty with the infection. And they're also at high-risk patients with dry age-related macular degeneration. And because of the pandemic, they're at almost a third risk, almost a third strike against them because of our office closures, our significant scheduling delays, and our telling them that they're not the urgent patients that we need to be seeing, and instead seeing our injection patients, our retinal detachment patients. So we're in the process of watching them get a third strike. For them and for us, really the question is, when are these patients going to be seen again? When will they want to be seen again? A lot of them are frightened and don't really want to come into the office. And a lot of them don't really have a good understanding of their disease, despite what we as retina specialists think we do in terms of communication. A lot of these patients don't really understand their disease, what makes it important for them to seek help. And what you're going to realize tonight, I think, and I hope that's the take-home message, is that we're not particularly good. Our social healthcare network is not particularly good at helping these people in general. And if under normal circumstances, our detection rates and long-term visual outcomes are poor, and I know a lot of you don't think they are, but you will think differently after the presentation. Really, what does COVID and the COVID crisis mean for these patients who may actually be delayed even longer before they're detected? And so what can we do to help these patients? That's really the question. This is a busy slide, but it's really, really excellent. It's very helpful. And this photograph depicts 4 different stages of choroidal neovascularization. On the left over here is the ideal situation where the choroidal neovascularization is just beginning, just the initiating sprouts and neovascularization. And the 2 panels to the right, unfortunately, are much more advanced choroidal neovascularization with leakage of fluid. These are the symptomatic patients. And unfortunately, if you go through the literature, and we will do that, you'll see that we're pretty much detecting patients in stages 3 and 4. I know you don't think we are, but we are. We're really not doing a good job of detection. And unfortunately, doing a poor job with detection means it's a poor prognosis for our patients. Under the ideal circumstance, and it's actually more practical now than you think, we would really like to be able to focus on the first and the second stages in terms of diagnosis. It's much easier to manage those patients at that level. It's much better for their patient's quality of life than to be detected late. And I'll refer back to this photograph later, but just keep it in mind because damage that's done in these first 2 stages in terms of anti-VEGF drugs and regression of blood vessels and neovascularization is going to be much smaller than the damage done to stages 3 and 4, to the retinal pigment epithelium, the surrounding photoreceptors are going to be much more impacted by this extensive network on the right. I had a suspicion because I've read a number of early trials and I've been involved with this device for a long time. And I felt like a lot of the poor prognosis and the delay in detection was mostly in the 2000 to 2015 era. I thought with the widespread use of OCT imaging, with optometrists, ophthalmologists, retina specialists, everybody having access to this kind of technology, that we would do a much better job of detecting choroidal neovascularization and the conversion from dry macular degeneration to wet macular degeneration. I thought it would occur at a much earlier stage. Alan Ho had an opportunity to review the data on this, and he found what we've known sort of, and he had an opportunity to review the IRIS registry data. And for those of you who are unfamiliar with this, this is the data that gets sucked out of many of our EMR systems into a big reservoir of data, big data, that's really very, very helpful in certain regards. And I think in this particular case, it gives us insight into really how we're practicing medicine, what we are doing for our patients, and really what we're not doing for our patients in order to help them. So Alan looked at the IRIS registry data, and I want to draw your attention to this upper left-hand panel. He looked at almost 250,000 patients to get this data. So this is not, rural Montana that we're talking about, where there's a study of 7 patients. This is US data, patients who had converted from dry macular degeneration to wet macular degeneration. And if you look all the way over to the right, in that right-hand column, you can see that the average visual acuity that patients are detected when they convert from dry to wet macular degeneration is 20/83. That I would not consider good. I wouldn't be proud of that data, but that is that's real data. And you'll see this data is reproduced over and over again in multiple clinical trials. Even worse than that 20/83 data is the fact that first eyes, the average visual acuity when patients are detected in their first eye with choroidal neovascularization is 20/85. And you would think, and this is embarrassing as a retina specialist, that by the time the second eye was detected and diagnosed, the vision would be far better than 20/79. But in the hands of retina specialists, okay, we've only go from 20/85 to 20/79 in the second eye. And that says a lot about our education. It also says a lot about our diagnostic capabilities. So that's one part of the graph that's a little bit telling. The other part, and this is even more important, I think, is if you look at the percentage of patients that are diagnosed with visual acuity of 20/40 or better, in this column right here, 55,000 roughly, or 56,000 out of 162,000 patients or eyes were detected with visual acuity of 20/40 or better. That's roughly a third, maybe a little bit more than a third, call it 35% of patients are detected with what we'll call good vision. And I will define 20/40 where vision is good vision, because if we talk to our patients, it's those patients who get below 20/40 that start to have difficulty with reading. They start to have difficulty with nighttime driving. 20/40 is a really good cutoff for good vision. Those goalposts sometimes change, as you'll see. Certain companies like to tout their drugs and use different criteria for what good visual acuity is, but we're going to stick with this 20/40 number, and you'll see over and over again that we haven't been very good at improving the prognosis or outcome of early detection. So first eye, all eyes, about a third. If you look at the first eyes, again, 34,000 out of 102,000, slightly over a third. That's again about 35%. And even second eyes, we're only 21,000 or 22,000 eyes with better than 20/40 acuity out of 60,000 eyes. Once again, we're talking about slightly over 1/3 of patients have good visual acuity when they're diagnosed with choroidal neovascularization. So I said earlier that this is what I kind of knew. I'm only surprised to see that in 2018, but this is data that shows that this has really been the pattern for quite some time. Now, the CAT and the IVAN study is the European version of the CAT trial, which was a trial to compare Lucentis and Avastin. But those are high-powered studies that had a lot of data in them. And then all these other studies that were done by private practitioners at places like Bascom Palmer, with this Olson study on the left. And then at Wills, 14% of patients had 20/40 or better vision in 2013. This is real world